Morning, everybody. So where we left off is slide 58 in the chapter 1 PowerPoint. So we are talking about oblique positions. So when we talk about oblique positions, we talk about the part of the body that is closest to the image receptor. So this here we are talking about the posterior obliques, and up here we are talking about anterior obliques. Okay. So as we talk about oblique positions, we are also talking the side of the body that is closest to the image receptor. This being the left side is closest to the image receptor. So we are calling this a left posterior oblique. So an LPO position. The left side is closest to the image receptor, the posterior side is closest to the image receptor, and the posterior side is obliqued. So left posterior oblique LPO position. On this other image, we are talking about the anterior aspect of the patient being closest to the image receptor, but we are also talking about the right side of the patient being closest to the image receptor. So when we describe this as the right side, the anterior portion, and it is obliqued. So this is an RAO position, the right anterior being obliqued, RAO. So we can also describe the same thing with these recumbent positions. This as a supine position, right? Because they are on their back, so supine position, and this is a prone position, okay? So what we were talking about here in this one is that the posterior aspect of the patient is closest to the image receptor. This one here, we are talking that the anterior portion of the patient is closest to the image receptor. So now we have to determine which side is closest to the image receptor. And if we notice, this is the right side here that's rotated up. The left side is the side that's down over here. So this would be considered a left posterior oblique. Okay, because the left side is closest, the posterior side is closest, and it is in an oblique position, so LPO. This one here, we can see that the left side is elevated, the right side is closest. So as we talk about this one, we talk side closest, so the right side is closest. The anterior side is closer, and it is obliqued. So this is an RAO position, okay? So moving on to the next slide, we have described these positions. So what we need to do is we need to look and we need to decide, do we have an anterior side closer or a posterior side closer? This is our anterior side that's closest, right? So our anterior side. And then we look here, this is our right side of our patient. This is our left side of our patient. So now we just need to fill in the rest of it because we already know that it is an oblique position, right? Because we are describing oblique positions. So the side that is closest is the right side. So we are a RAO position. Okay, so on this next one over here, what we're looking at is which part of the patient is closest to the image receptor, and that is the posterior side that is closest to the image receptor. It is an oblique position again, right? So we can add the O. So now we know that it is a PO, so a posterior side that is oblique. And now all we have to determine is it the right side that's closest or the left side that's closest? So if we look at this patient, we know that this here, the elevated side, is the right side, and the down side over here is the left side. So now we are in an LPO position. If we look at this, This is the direction of the beam, right? So the direction of the beam is coming down. The direction of the beam is entering the anterior portion of the patient. It is traveling through the patient. It is exiting the posterior side of the patient. So this is an LPO position, right, with an AP projection, right? Projection. So the projection is the path of the beam. The LPO is the position of the patient. So decube positions, when we talk decubitus positions, they are designated by the surface on which the body is resting, lying down, always performed with a horizontal X-ray beam, essential for detecting air fluid levels. So our decubes are essential for detecting air fluid levels. They will have a horizontal beam, and they are designated by the resting side down, okay? So we talk about this image here first. This side that is down, this is the left side, and that's where they've got the left. So lateral, they're on their lateral position. So left lateral decube. It is an AP projection because it's entering the anterior portion. It's traversing through and exiting the posterior portion. So AP projection. Side down is your left side. So left lateral decubitus. On this one, right lateral decubitus, we know that this is the right side that's down, so we talk about it as the side down. So right, they're in their lateral position, right lateral decube. PA projection because it's entering the posterior aspect, traversing through the body, exiting anterior. So it is a PA projection, posterior to anterior, PA projection, a right lateral decubitus. They are for detecting air fluid levels. Dorsal and ventral decubitus. So when we talked about our body, we have dorsal, which is the posterior, right? So posterior, or the back of the patient, right? So the back of the patient. Okay, so back of the patient. Ventral, that is the front of the patient, right? So front. And you can also say that this is supine, right? So supine. This is prone, right? So these are interchangeable. When we're talking as far as decubes, we're not going to say a supine decube or a prone decube. We're going to say dorsal decube, ventral decube. Once again, it's got a horizontal beam. So the horizontal beam is entering one side of the patient. It's traversing through and exiting the other side of the patient. So it's going to either enter right or left side and exit the opposite side, either the right or the left side. So dorsal decube. Left lateral, we talk about left, the ventral and the dorsal as the side closest to the image receptor. So the left side is closest. This is the right side over here. So our dorsal and ventral decubitus positions. Dorsal decube because they're on their back. They're supine. Okay, so this is the dorsal, and it is a left lateral because we talk about it as the side closest to the image receptor. Once again, it is a horizontal beam. So this prone side, this is a ventral decube. It is a right lateral, okay? So right lateral because the right side is closest to the image receptor. It is entering the left side, exiting the right side. Ventral decube, right lateral because the right side is closest, so we call it the right lateral ventral decubitus. It's got a horizontal beam again. It is entering on the left side, traversing through, and exiting on the right side. That's why right lateral ventral decube, or ventral decube as position, right lateral as which side's closest to the image receptor. Radiographic projections describe the direction or path of the central ray of the X-ray beam. So this is the path of the beam entering here or coming from the tube. It enters here, traverses through the patient, and hits your image receptor back here. So this is entering the anterior aspect, right, and exiting the posterior aspect because the posterior is closest to the image receptor. So this is an AP, anterior posterior projection. This one over here, if we follow the central ray from the tube to the patient, right, it enters the posterior aspect of the patient and exits to the image receptor on the anterior aspect, which is closest to the image receptor. So it is a PA projection. So entering the posterior, exiting the anterior, which is closest to the image receptor, PA projection. AP or PA oblique projections. So this is an AP oblique, right? Because now we have the body part is angled, the body part is an oblique projection. It has medial rotation. So what we're saying is we're rotating the foot or the leg medially, right? So that's coming towards the medial aspect of the body. It is entering anterior up here, exiting posterior closest to the image receptor. And then over here, we have a PA oblique, right? Because once again, the hand is in an oblique position. It is lateral rotation because the lateral rotation is moving away from your midline of your body. Your midline of your body is over here. So it is a lateral rotation away from the midline of the body. So PA oblique because this is the posterior aspect of the hand. Remember how you stand in the anatomical position. So the back side of the hand is your posterior aspect. So we are entering posterior, exiting anterior. That's why we have the PA. And then it is an oblique position because that hand is oblique and it is moving lateral. So it's a lateral rotation. PA oblique lateral rotation, just like the foot is an AP oblique medial rotation because the midline of your body is over here. So medial rotation is moving towards the medial aspect of the patient. Describe these oblique projections, okay? So when you're looking at the x-ray here, what you're looking at is you're looking at the patella. So which way is the patella moving? And then you have to know, where is my tibia? Where is my fibia? Is my fibia medial or is my fibial lateral, okay? So lateral. And then we look at our midline of our body here. We look at our hand. This here is the posterior aspect. So we have a rotation medial, right? So it's not an AP position. It is a AP, right? Because this is your anterior aspect, the back of your elbow is your posterior. So AP projection, and it has a medial rotation. This here, since we know that our fibia lies lateral, what is happening? This is opening up, and our patella. So if our patella is in the middle of our femur in an AP, and now our patella is starting to move in, so medial, this is our medial aspect here, because we know that our fibula lies lateral. So if our patella is moving medial, this is an AP. And then once again, it's got that medial oblique position. So AP, medial oblique. This here is also an AP because the beam is entering anterior, exiting posterior. So AP, medial oblique, because your hand, your arm is coming medial to that medial aspect of the patient. Lateral projections. So we talk lateral projections also as, are we going lateral to medial or are we imaging medial to lateral? So we know that this is the inside of the leg. So this is the medial aspect of the leg. The leg that's on the IR is the lateral aspect. So this is being imaged medial to lateral because your X-ray beam is entering the medial side, exiting the lateral side. So a medial lateral projection of the ankle. So lateral to medial, we know that our thumb, according to anatomic position, is lateral. So being it's entering the thumb side, it is entering lateral and then exiting down here medial. So lateral to medial is the projection of the wrist here. So lateral medial projection of the wrist. Special projections and terms. This is an AP axial or semi-axial projection. So if you think about it, this is the anterior aspect, this is your posterior aspect, and any angle of the central ray 10 degrees or more along the body part is considered an axial projection. So we have an angle that is 10 degrees or more, so it is an AP, anterior posterior, AP axial projection. Axial projection here, because you can see the central ray, the travel of the beam is angled, right? Say that this is 90, so this angle here is 10 degrees or more, and it is entering superior up here, right? Superior up here, exiting inferior down here. So this is an axial superior inferior projection. Which projection is this? So first thing that we have to look at is our central ray angled or is it coming in perpendicular? So we can see that there is an angle here, right? So then is it entering the inferior portion first? Inferior? So it is entering inferior, so it's in the armpit, inferior, and exiting up here, superior, right? So this is an axial inferior superior projection. Okay, and it's going to give us this as the X-ray image of that shoulder. So axial inferior superior projection. Inferior superior axial shoulder. You can also say axial inferior superior, inferior superior axial. It doesn't matter how you term those, which order they're in, as long as those are there, that it is an axial projection because it has that angle. And then how is it entering? It's entering inferior superior. So the order of these words here don't really matter as long as you understand what they're talking about. A tangential projection. So tangential projection is one that skims a body part, okay? So we can see here that the central ray is coming down. It is skimming this body part. It is a tangential projection for your zygomatic arches, okay? So this is an image here, this is an image here, this is an image here. They're separate. So what they did was they imaged this side, then they came back and imaged the other side. So you have two images, but it is tangential because it is skimming that body part. And you could technically say that this is a tangential projection that is entering inferior and exiting superior. So you could say tangential, inferior, superior. You can also say that this is the anterior portion. This is the posterior portion. So it is an AP, anterior posterior projection, inferior, superior, but most importantly, it is tangential because it is skimming this body part and making that image. So tangential patella. So we use tangential projections to image our patella. You can see the patella right here on that. And the way to image that is we are going to place our central ray and we are going to skim this body part. So it is a tangential patella. This is also called a sunrise. A sunrise image because it makes the patella look like it is the sun rising above the landscape, but tangential. So which projection is this? If we went ahead and looked in our book, we know that this is a special projection of the chest. So we're going to go ahead and talk about it, but we can also come across or think of it in some of our positioning. So our central ray is perpendicular to the image receptor. It doesn't have an angle, so there's no axial. So now we're going to talk about what does it hit first. It hits the anterior portion first, traverses through the anterior portion, exits the posterior portion. So this is an AP projection, but then we have a position of the patient, right? So AP axial apical lordotic chest. So our beam is perpendicular, but what we've done is we've angled the patient. The patient is angled 10 degrees or more. So then it is an axial. We're using the patient to produce that axial angle, not the beam. So this is an AP axial lordotic chest, and it is used to exaggerate the lumbar curvature. It's also used to move your clavicles here above the apices of your lungs, so you don't have the overlay of the clavicle in the apices of the lung. So this position, AP axial lordotic chest, the angle of the tube is not changed, but you're using the patient to create that angle. So it's from its normal AP or PA chest, the lordotic axial, because the patient is angled. So name this projection. So if we're naming this projection, what we have to think about is which side of the patient is closest. So this is the right side that's closest, and you can see that with the marker because we mark the side that's closest. The patient is lateral, so this is a lateral, right? And then what we're going to say is it is a lateral. So it is a right lateral projection. Name these projections. So we have an angle here. Sorry, I lost my pen. Okay, so we have an angle here, and we are entering anterior, exiting posterior. So this is an AP axial foot. We have an angle here, right? And we are imaging the calcaneus. So we are entering the posterior aspect. We are entering, we're entering the plantar aspect. And then we exit posterior. So this is going to be a plantar dorsal axial projection of the calcaneus. Okay, so we are entering the plantar portion, exiting the dorsal portion because this is considered our dorsal portion. So plantar dorsal, axial projection of the calcaneus. So some unique projections that we have: parieto-acanthial. So we are entering the parietal aspect, and then we are exiting with our central ray towards the acanthial portion. This one here, we have an axial projection because we've got that angle, but it's entering the acanthial portion and exiting at the parietal. So acanthial parietal projection, opposite of this parietal up here, exiting the acanthial. So parietal, acanthial, acanthial, parietal, and then SMV, submento, because it is below the mentum, this being the mentum up here. So submento vertex is the vertex of the skull is on the image receptor. So submento, below the mentum to the vertex, submento vertex, SMV of that projection. So relationship terms, we talk medial versus lateral. So medial versus lateral, as we've talked about in the past. This is your medial aspect. So everything from here moving this way and this way is lateral. Okay. So if you start discussing it from this way to here, then you're moving lateral to medial. Here is medial to lateral. So proximal versus distal as well. So this up here is proximal, this down here is distal. So you can also talk distal or proximal, and then you can talk medial or lateral. So as they've pointed here, this is your lateral abdomen because this is your medial abdomen. This is your lateral aspect of your arm because this is your medial aspect of your arm. This is the part of the lateral hand because this is part of the medial hand. This is distal, right? And then as you start to move up here, this becomes proximal because it's getting closer to the upper aspect of your arm. Caudal and cephalic, and then CR angles. So which angle? So is this angle of the beam, is it moving caudal or is it moving cephalid? So cephalic or cephalid, this is towards the head. And I remember that because it has the H. So cephalid, cephalic, that is towards the head. So this is the cephalic angle. So cephalic angle here, okay, because it's moving towards the head. This angle here that we started with, this angle here is towards the feet, right? So that's towards the feet. So that is caudal. So this is your caudal angle. So caudal angle towards the feet, cephalic angle, cephalid angle is towards the head. Movement types. You have flexion versus extension. So flexion in your arm, you can think as you're flexing your muscles. So flexion here, and then extension, you're extending your hand. Flexion, you're bending your foot up, so you're flexing your leg here, and then or you're extending your leg out. So you have to extend your leg to kick somebody. You have to flex your leg to get ready to extend it really fast to kick somebody. Flexion, you're showing your muscles. Extension, you're reaching out, you're lowering your hand. So extension and flexion. Movement types. There is hyperextension versus extension. So extension is your neutral aspect of your spine. This is typically your C-spine. So your extension, this is your neutral position, the way you hold your head naturally. Hyperextension, extension, this is moving back. So your head is moving back. These are your spinous processes. So you're squeezing your spinous processes together. Your head is looking up towards the ceiling. That is hyperextension. Flexion. Flexion, you are looking down to the floor. You're separating your spinous processes here. So flexion. The way to remember it is flexion, F for face. So face is going down. That is flexion. Extension, hyperextension. Your head is looking up. You're facing up. So hyperextension, face up. Flexion is face down. Movement types, hyperextension or dorsiflexion. So this is the palmar aspect. The backside is the dorsal aspect. So you're moving that dorsal aspect back. So you're dorsiflexing or hyperextension, right? So you're bringing that palm up. That is your hyperextension or dorsiflexion. And then you have acute flexion. It's basically laying the hand on the posterior aspect, the dorsal aspect. Your palm is up. Your arm is pushing down. Acute flexion. So movement types, radial versus ulnar deviation. So deviation is basically you're deviating your hand towards the ulna. So your hand is moving towards that ulna aspect. Your radial deviation is moving everything towards the radius. So now you're moving your hand towards the radius. So radial deviation towards the thumb side. So you're bringing your palm, your hand more towards the radius, or your hand more towards the ulna. Ulnar deviation, radial deviation. Dorsiflexion versus plantar flexion. So we know that the bottom of the foot is the plantar portion. The bottom of the foot is the plantar portion. So as we go down, point our toes down, that is the plantar flexion. If we start to point our toes up, that is dorsiflexion. We're pulling our toes up towards the ceiling, towards our head. That's dorsiflexion because we're showing more of the dorsal aspect of our foot. Stress movements. This is stress movements of the ankle joint. So inversion, eversion. So eversion away from the body, inversion towards the body. Sorry, we'll go back one. So this is away from your midline. So your midline is here because our first toe, the big toe, is medial. This here is the medial aspect, so you're moving more medial. Inversion towards the midline, eversion away from the midline. Those are stress movements of your ankle. Medial versus lateral. So we know that the thumb side is the lateral side in that anatomic position. So if we rotate to bring our thumb out, we are moving in a lateral rotation. If our thumb side being the lateral side, now we're moving it in towards the body, towards the midline of the body. That is a medial rotation. So medial rotation, lateral rotation. Abduction versus adduction. So the way to think about this is you're adding it to your body. So you're adding it. Adduction is towards the body. So adducting, I'm adducting my arm. So I'm moving my arm towards my body. Abduction, think about it as being abducted by the aliens. So the aliens are taking you away. So they're moving your hand away from your body. So it's being abducted. Abduction is away from. Supination versus pronation. Pronation is the palm side, so you're pronating. You're moving the palm down, so you're moving from the supinated side, supine, to the pronated side, palm down pronation. Supination is from the palm down to the palm up. So moving from this, which is palm down, to the palm up, right? Up. So supination versus pronation. Supination, you're putting the palm up. Your supination, palm down, pronation. Some protraction and retraction. So in your jaw, if you retract, you're moving your jaw back. Protraction, you're moving it forward. You're protruding it out. So protraction, jaw out, jaw back. Protraction, retraction. Elevation, you are going to bring your shoulders up, right? So that's elevation. Depression, you're moving your shoulders down. You're depressing them. Movement type still, circumduction movements, when you're able to move it in a circle. So you can circle your finger, you can rotate your wrist, your finger, your leg, so they can move in a circle. Circumduction movements. Rotation versus tilt. So you can see here that if you look at this interpupillary line, one side of the head is coming down towards the image receptor, so that's rotation. You are rotating towards the image receptor. If you draw a straight line here, you can see that it does not match this straight line, so that is tilt. We are actually tilted down towards the image receptor. So our interpupillary line is not perpendicular. Our sagittal line is not parallel with our image receptor. It has tilt. So superficial and deep, this should be simple. So our bones are deep, right? So deep, and then our skin is superficial. So superficial skin, deep bones, and then we talk about everything else as we go along there. Are they superficial or are they deep? So we're going to do some review. So if we look at this patient, we know that the right side is closest. The left side is farthest. We talk about it as the side that's closest. So this is a right lateral position, correct? So our beam is going to move lateral through the patient. The right side is closest, so right lateral. This here, we have an angle. If this angle is 10 degrees or more, we have to use axial, right? So axial. So we are entering the anterior, okay? And we can say that this is posterior. So this is an apiaxial foot. So anterior, posterior, apiaxial foot. You can also say that it is dorsal plantar because this is the plantar part, but usually it's talked about as far as AP. So anterior to posterior, apiaxial projection of the foot. So we know that this is our midline. So this is the medial to lateral. So this is your knee, right? And if we look at this, it is going to be the left knee, okay? So left knee. And it is a medial lateral left knee. Normally, it's just called a lateral knee. So which knee? Is it right knee or left knee? This is our left lateral knee, but it is the The position is the left lateral knee. The projection is medial to lateral. So you want to say left knee, medial lateral projection. So some terminology review: a projection in which the central ray is parallel to or greater than a 10-degree angle along the long axis of the body part would be axial, right? Projection that merely skims the body part, we talked about that as the tangential, right? A projection in which the hand is pronated, so it's on its palm, and then rotated laterally 45 degrees, right? That would be a lateral movement. So oblique projection, right? So we are at an angle of 45 degrees, so an oblique projection. Tangential projection, where it skims the body. Axial projection, anything that is 10 degrees or more of an angle, either the tube or, as we talked about for the lordotic chest, for that lordotic chest, we're angling the patient. So we angle the patient or the tube, anything that is angled 10 degrees or more. So a specific oblique position in which the right anterior aspect of the body is closest to the IR. So oblique, we have the O, right? And then we have the right anterior aspect. So R, A, O is closest to the IR. A body position in which the patient is lying on the abdomen, right? So on the abdomen, that means that they are prone with the X-ray beam directed horizontally. So horizontally. So if they're laying on their abdomen, is that ventral or is that dorsal? That would be ventral, right? Ventral, and then the X-ray beam is directed horizontally, so that would be a ventral decube. A general body position in which the head is lower than the feet. So the head here, and then the feet are up here. So there's two of those. There's Trendelenburg or Fowler. So which one would that position be where you are, the head is lower than the feet. So the head is down here, right? So we have recumbent RAO position. We have a dorsal decubitus projection. And then we have a general body position in which the head is lower than the feet, Trendelenburg. So let's think about this one here where it's dorsal decubitus projection. I'm going to go back up here because I think that that is wrong. Laying on your abdomen, that is a ventral decube. Laying on your spine, that is a dorsal decube. So if we go back down, we are going to realize that that is wrong. So a body position in which a patient is lying on the abdomen, right? It is not dorsal. It is ventral. With the X-ray beam directed horizontally, ventral decubitus position. The only way it could be dorsal is if they are lying on their back. So that side is down. Remember, we talk side down. This, on number 5, body position which the patient is lying on the abdomen, that's the side that's down. So that is your ventral side that's down, ventral decubitus. Radiographic view, not an accepted positioning term in the United States. View describes the body part as seen by the image receptor or other recording medium, such as the fluoroscopic screen. So, positioning principles. So, basically, your radiographic view, you are viewing everything for the most part in anatomic position. So you are viewing that image as if you're actually looking eye to eye at the patient, okay? So, objectives. Here we are going to hypothetical clinical situations, identify responses, identify correct sequence of steps. Given a set of circumstances, apply general rules of radiography, and then identify the correct way to view the radiograph, CT, or MRI. So positioning accuracy, you want all the pertinent anatomy demonstrated, which means when you collimate, everything in that light is what's going to show up. So do you have everything that's required for the image? Multiple images are going to be used, aligned on the image receptor. You're going to use collimation. You may have to rotate the hand, and then you're going to pay attention to your central ray. So, evaluation criteria, this is a lateral forearm. You want all the anatomy demonstrated. And when you're imaging long bones, you need both joints, the distal joint and the proximal joint when you're imaging long bones. So, elbow and wrist joints both are included. You want the proper position. You don't want rotation at the wrist, at the elbow. So you want the proper position for the image that you're imaging. Your exposure, you want your optimal exposure factors, and then you want the proper marker visible. So you're using the correct anatomic marker. If this is a right forearm, you want to use the right marker. Essential IR markers, your anatomic side, you want to mark the correct anatomic side. So they used to, in the past, they used to have to put patient ID on the image. Now your patient ID comes on the image computerized onto the image. So it will come on there. Your date of your exam will be digitally expressed on that film. But your anatomic side marker, that is something that you need to place on the image. So you know that you are on the correct side. So the radiologist can see the anatomic marker for the correct anatomic side. So some sample procedure markers, sometimes these are in the department, sometimes they're not. Nowadays, what you can do is you can post-process this stuff, so you can type lateral, you can type before, you can type after, you can type flexion, extension, that sort of stuff. Scout, if it was a decube, whether it was erect or supine, you just have to make sure that your right or left anatomic marker is on the image and it is the correct right or left side. So positioning rules, minimum of 2 projections. So the way you think about this is minimum is 2 projections, and what you're looking at is 90 degrees apart from one another. So anatomic structures superimposed, localization of lesions or foreign bodies, determination of alignment or fractures. So remember, our images are 2D images. If you look at this nail, can you tell me for certain, is the nail in the anatomy. Is it actually in the person? Is it under the skin? Is it in the bone? Is it posterior to the patient? Is it just laying on the image receptor, right? This one does not give you an idea of where it's at. When you make this lateral, then you can see that this nail is through the skin of the patient, through the soft tissue. It has not damaged the patella. It is not in the bone, but you can locate the depth of it. So that's why you take two images 90 degrees or close to 90 degrees apart from one another, as close to 90 degrees as possible. So once again, we talk about this one. So this is your AP position, and you can see all of the hardware that's in here. You can see your fractures down through here. You can definitely tell that it's broken bone. Now you take the one 90 degrees apart from it, a lateral position, and you can see now the hardware's moved out of the way. You can still see some of the fractures. They don't look as bad as they did on the anterior portion or the AP position of the patient. So common positioning rule, minimum of two projections 90 degrees apart from one another, especially in a trauma situation or if you're localizing a foreign body or a lesion and or determining alignment of any types of fractures. So as you can see here, this is a child that has a foreign object that they have swallowed. But in this image here, you can't tell me. This could be that child has a necklace, say, with a round thing on top of it, and it's just laying on top of the patient, or maybe it is a button on the back of a gown or something, and I don't know where it is. But if I take this one over here, a second image, because we now are looking at depth, we can tell that this is inside the patient. The child did swallow it. It is stuck. It is a foreign object that was swallowed. Two images 90 degrees apart from one another. So as we can see here, this is an AP projection. We can see that there are some fractures here. Something going on up here. Okay, so this is one image that we took, and then we take the second image, and the second image 90 degrees or as close to 90 degrees apart. We can definitely tell that the fractures are much worse than what they looked like over here. So trauma situations, two images 90 degrees apart from one another, that is the minimum. Okay. So, positioning rules and principles, minimum of three projections. Sorry. I keep losing my pin. So, minimum three projections when joints are in prime interest of the area. So when your joint is of interest, so it's not a trauma, it is joint pain, can't move, something like that, then you have a minimum of the three images where you're going to do AP or PA, a lateral, and an oblique. So non-trauma, joints, three images. Trauma wrist, minimum two, right? So your long bones require two projections. So if you're doing a hand, a minimum for a hand is going to be three. So you're going to do an APPA, an oblique, and a lateral. Wrist, the same thing. But then you go to your forearm. Those are two images. Your humerus, two images. Femur, two because it's a long bone. Tib fib, two images, AP and lateral, because it's a long bone. So long bones require two projections, include both joints. So no matter what long bones you're doing, you are including both the distal joint and the proximal joint in that imaging. So exceptions to the rules, post-reduction. Sorry, I don't know why it keeps doing this and losing my pen. So exceptions, post-reduction, upper and lower limbs, post-reduction, possibly 2 images, depending on what the upper limb is. Pelvis study projection. A pelvis is a single image unless a hip injury is suspected, and then you're going to do pelvis and hip. But normally if it's just a pelvis image, that's a single image, 1 image for your pelvis. Abdomen, KUB. KUB stands for kidney, ureter, bladder. That is a single image as long as you've included the entire kidneys, your ureters, and your entire bladder. These usually require only 1 projection. So post-reduction, a pelvis, a KUB. Chest x-ray on critical patients is often only 1 view. So you think about your chest x-rays as inpatients that need a chest x-ray like every morning. That's a single picture. It's an AP projection. You don't do a lateral, so that's 1 projection. So post-reduction on most things is going to be a single picture. Pelvis image is going to be a single picture. Abdomen KUB is a single picture. And then chest x-ray on critical patients, that is a single image. So a hand, is it 1, 2, or 3 projections? Forearm, 1, 2, or 3. So a hand is going to be 3 projections. Forearm, that's your long bone. That's 2. Femur, that is a long bone. So that is 2. Your knee, that is a joint. So that's 3. Humerus, once again, that's a long bone. That's 2. Just remember, on the long bones, you need both the distal and the proximal joint. So, hand, as we said, that's the 3 projections. The forearm, that is the 2 projections. The femur, 2. Knee says 2 projections. And what I did was knee, I did 3 because it is a joint, right? And it should be 3. So they've got knee as far as 2. I consider it 3 because it is a joint. And then humerus 2 because it's a long bone. So long bones or anything that's a joint is going to be 3. Palpation of topographical landmarks. So we palpate. We don't tell our patients, I'm going to feel for a bone on you. I'm going to touch a bone on you. So we tell them that we're going to palpate or locate. Okay. So don't feel, don't touch, palpate or locate. And we'll talk about these 2 words more. So apply light, gentle pressure, light, gentle palpation with your fingertips to locate those positioning landmarks. You must inform your patient before the process because you don't want somebody just coming up and palpating all over you without saying, hey, I am going to locate this bone for positioning. Is it okay if I locate this bone for positioning? Is it okay if I locate for my position? So always inform your patient what's going on. We talk about our image receptor as far as are we going to the alignment of the image receptor. Is it in a portrait position? Is it in a landscape position? So portrait is lengthwise. So you talk about lengthwise, right? So 14 by 17 lengthwise, or you talk about 14 by 17 crosswise. And we discuss the lengthwise and crosswise according to the anatomy that we are imaging, okay? How is it best going to fit on that image receptor? So do we need it in a lengthwise position or do we need it in a crosswise position? So LW lengthwise, CW crosswise, as far as placement of that image receptor. So placing radiographs for viewing, patient is facing the viewer. So if you're looking at that image receptor, that patient is looking at you. Patient's right is to the viewer's left. So if you're looking at that image receptor, your left hand, when you point to the image, you're pointing to the right side. Your right side is aligned to the left side of that patient. So lateral projections common to view from the tube side. So if it is a right lateral, then as you look at it, you're looking at the left side to the right side. Perspective or the doctor's preference. Decubes, they're viewed from the tube perspective, right? The upside of patient is up. So we'll talk about decubes and how they're viewed and how radiologists like them to be sent to them as well when we're in class, when we're in the lab. Lateral radiographs, so the limbs, those are anatomic position with limbs hanging down. Hands and feet, so anything with your digits, those are usually placed with the digits pointing up on the computer screen. And then your forearm, those are digits up is a most common preference. So you're not going to hang or send the forearm with the digits down in that anatomic position. That forearm is going to be sent where your digits are up. It's just the preference for those viewing of those radiographs. And we'll talk about that more as well as we go on, but just understand now that limbs, your tib fib, your femur, your humerus, those are hanging in anatomic position, limbs down. Your forearm is most common preference with digits up. Your hands and feet, since they have digits, those digits are usually placed up for viewing. So viewing radiographs, AP chest, right? So this is your AP chest. Here, left appears right side up. So left appears right. So this is your AP chest. So that travel of the beam enters the anterior aspect, exits the posterior aspect. So this is more of an inpatient. So your left side here, your right side is going to be over here. I'm looking at this in anatomic position where my left side is positioned on the right side of the patient. So this is anatomic position for an AP. PA chest, left appears reversed. So this L appears reversed because when it was placed on the image receptor and we made that exposure, it flipped this image. So it inverted the left marker, but it placed it in anatomic position. So this is left, this is right, okay? The reason this one is not flipped is because it was imaged anterior to posterior. This one here, the PA chest, was imaged where the beam hit the posterior aspect, entered the anterior aspect. So when that image comes to the computer, it flipped that image and placed it in anatomical position to where we're viewing it as right on the right, left on the left, but it's inverted that left marker. We will discuss that more in lab, but you can always let me know if you have questions about it. So viewing radiographs, left lateral chest, This means that that left side is closest to the image receptor. It's a 2D image. So basically we can say that we're looking from the right side to the left side, with the left side being closest. Left lateral to cube means that the left side is down. We mark the side that's up. So we're talking about the left side down. That's why it's a left lateral to cube. For air fluid levels, normally these images are twisted and sent to the radiologist in anatomic position. So they're showing you this image in this left lateral to cube, so you know that the left side is down, the right side is up. They even placed an arrow indicating that this is the side that is up. So in your decubes, we normally mark the side that's up with our anatomical marker, make sure it is the correct anatomical marker, and we discuss the image as the side that's down. Left lateral to cube. We'll have a right marker because you're marking the side that's up. The left side is the side that's down. Viewing radiographs. So as we talked about, digits. So digits are in the up position. Forearm, digits in the up position. Humerus, anatomic position, digits down. Pelvis, femurs down. This is your knee up here. This is a long bone. Your ankle is down here. So we've included both joints in the long bone, the knee, and the ankle. Also in the forearm, we've included both joints, the wrist joint, the elbow joint. In the humerus, we've included the elbow joint and the shoulder joint. And then in the foot, once again, those are digits up, just like the hand. That is common practice for those images to be hung, those images to be sent to the radiologist for viewing. So once again, we kind of talk about CT and MRI to better understand our coronal imaging, our sagittal imaging, and then transverse or axial. So in this coronal, if I scroll this image, I'm going to look from the back of the head to the nose, or the nose to the back of the head. So your coronal, anterior, posterior. This is your sagittal. So if I scroll this image, I'm going to look from right side to left side, or left side to right side. Transverse or axial. Basically, I'm going to scan from the head of the patient all the way down through the body to the foot of the patient, or from the foot all the way up to the head of the patient. So we do have some positioning landmarks that we talk about. So our jugular notch, also called our suprasternal notch, or the manubrial notch, and make sure that you understand all three of these and are able to remember them, because we're going to talk about them as either the jugular notch or the suprasternal notch or the manubrial notch, and that is right here. So jugular notch, suprasternal notch, or manubrial notch is around that T2, T3 position, and T2, T3 refers to the thoracic vertebrae, so T2, T3 aspect. Our xiphoid process, xiphoid tip right here corresponds to T10, and if you come across, you can see that it's around T10, so thoracic 10. Mid-thorax T7, so our mid-thorax, where our central ray is for our chest x-rays, is around that T7 aspect, that thoracic spine 7. And it is also the inferior angle of the scapula. If you could see the scapula is back here, that inferior angle of the scapula would be somewhere in there. So the mid-thorax, the inferior angle of the scapula around T7. So averages for that T7 to be found. Female patients is about 7 inches. Male patients is about 8 inches to locate that T7 aspect, or the inferior angle of the scapula. So usually if you place your pinky on C7, vertebral prominence, and spread your pinky and your thumb out. That is around 7 to 8 inches, or if it's 7 inches, then you know that you need an inch below your thumb for those central rays. 7 inches, 8 inches, anywhere from 18 centimeters to 20 centimeters. We'll discuss that more in lab when we start positioning for the chest. But understand, pinky to thumb, around 7 to 8. And you can measure that at home. You should have a ruler. You should have a tape measure. You can see what that is on yourself, so you kind of have a better idea when you get to lab. So topographical landmarks for an AP chest. T7 is approximately 3 to 4 inches below the jugular notch. So if you find your jugular notch here, the jugular notch, suprasternal notch, manubrial notch, and go about 3 to 4 inches inferior to that, that is where your central ray is going to be for approximately T7 for your AP chest. So some other topographical landmarks, we have mid and upper abdomen landmarks. So our xiphoid process we already talked about. T10 or T9, T10, somewhere around in there. It can either be T10 or it'll show up as T9, T10. Your inferior costal margin, which is your lower rib margin, right here. So number 2, that is around L2, L3. So lumbar 2, lumbar 3, and then your iliac crest. Your iliac crest right here. So number 4, if you come across your iliac crest, number 3, you come across iliac crest is going to be around L4, L5, which is lumbar 4, lumbar 5 in your vertebral spine. And then we have ASIS. ASIS is anterior superior iliac spine, and that is a palpable landmark. So that's number 4, usually around right here. Your greater trochanter. This is your greater trochanter right here, and it usually corresponds to the level of your symphysis pubis, okay? So number 5 is your greater trochanter right here. Your symphysis pubis is number 6. 7 is your ischial tuberosity, which is here. Your ischial tuberosity is not palpable. Your symphysis pubis is a palpable landmark. We just do not palpate for it. Our greater trochanter is palpable, and we can palpate for that greater trochanter. And our ASIS is a palpable landmark, and we can palpate for it. So the takeaway on here is don't palpate for the ischial tuberosity. You just need to know where it is. Your symphysis pubis, you need to know where it is. It is a palpable landmark. You just do not palpate for the symphysis pubis. Topographical landmarks on this image here, we have the iliac crests. So our iliac crests, we have our ASIS, we have the symphysis pubis, we have the greater trochanter, and we have the ischial tuberosity. Out of all of these, once again, I will say that you can palpate the iliac crest, you can palpate the ASIS. You can palpate the greater trochanter. The symphysis pubis is palpable as a landmark. You just don't palpate for it. The ischial tuberosity, we need to know where the ischial tuberosity is, but we do not palpate for the ischial tuberosity. Body habituses. There is hypersthenic, there is sthenic, hyposthenic, and asthenic. So know those 4 body habituses, know the percents associated with them. So hypersthenic 5%, sthenic 50%, hyposthenic 35%, and then asthenic about 10% of your population. and you can visualize what's going on within the anatomy. So hyposthenic, the lungs are wider, shorter. The sthenic, the lungs are wide, they're starting to elongate a little bit. Hyposthenic, they are starting to elongate even more. Same thing with the asthenic, they are very long. And then if you look at your colon, you can see that the transverse colon is high and across. In the sthenic, it starts to drop down a little bit. In the hyposthenic, your transverse colon starts to come down closer to your sigmoid colon. And then in the asthenic patient, your transverse colon makes a very good J as it dips really low and then has to come back up to the splenic flexure and then down the descending colon. So body habitus determines the shape, the position, the movement of your internal organs. The diagrams show the general appearance of the thoracic cavity of different body types, so make sure that you understand those. Sthenic, hyposthenic, hypersthenic, asthenic, and then your book, which is a newer edition, also talks about bariatric patients as far as obesity. It is something that needs to be talked about more. You will encounter many bariatric patients in your clinical settings, and so understanding their body habitus is going to be very important. So the 4 types of body habituses that were recognized before the obesity: the hypersthenic, the sthenic, asthenic, and then hyposthenic. So make sure that you pay attention to those body habituses. You understand the 4 body habituses and what's going on with the anatomy. Once again, just another images of hypersthenic, sthenic, hyposthenic, and asthenic, highlighting the lungs. You can also look at the transverse colon as well as what we did on the other one, just a reinforcement of what the lungs look like in this one. So on images, we can tell that this hypersthenic patient, right? You go back over here, hypersthenic, about 5%. They are short lungs, they are wide. So we come down here, they are wide, they are shorter, okay? And then hyposthenic, they are long, right? So we go back to this one here. So hyposthenic, we have the really long lungs, okay? They're a little bit more narrow. So we look back at this, they're a little bit more narrow, but they are long lungs. All right, so that brings us to the end of this PowerPoint. Let me know if you have any questions on it, and we will see you in class after this storm.